Welcome to the deep dive. So if you're an emergency department practitioner, well, you know the drill. You're working with a lot of autonomy, it's high pressure, but sometimes the training, especially given the different backgrounds people come from, can feel a bit fragmented, maybe, like separate pieces rather than a clear path.
Yeah, exactly. And that fragmentation, it can introduce risk, not just for patients, obviously, but for you professionally, too. You really need a system that properly defines competence, standardizes things, and, protects your scope of practice.
And that's really the heart of our deep dive today. We're looking closely at a big proposed change, a framework that looks set to redefine EP education. It's about aligning the curriculum with, well, the gold standard language in emergency medicine,
Yep.
the Royal College of Emergency Medicine's specialty learning outcomes, the SLOs.
hmm Our mission here is pretty straightforward. We want to give you a kind of shortcut to understanding where things are heading professionally. This mapping idea, it really feels like the next iteration of the curriculum. It's not just more paperwork, it's about structure, it's about clarity, and maybe most importantly, it's about future-proofing the EP role within the whole ED team.
Okay, let's unpack this.
Right, let's start right at the beginning. What exactly are these RCEM SLOs?
Well, they're basically the fundamental kind of overarching competencies. They don't just list facts you need to know. They define functional performance. The big tasks, the high-level stuff a practitioner has to be able to do safely, independently.
So the shift is really away from just memorizing stuff towards actually doing things. The examples in the sources, they sound less like exam topics and more like, well, job descriptions almost. Things like manages the critically ill patient or manages complex decision-making and risk. Exactly. They define the outcome you're aiming for with the training. And, that immediately brings up a key question for anyone listening. Why take this high-level framework, something often linked with consultant training, and apply it to a role that's mainly focused on minors?
That's a really good point. For you, the person learning the benefit seems pretty immediate. It gives context right away. The old way might have been, just, I need to learn about asthma management, kind of in isolation.
Whereas this new way, the SLO-Mapped approach, it give it purpose. You understand now that learning about, say, severe asthma attacks directly helps you meet that SLO of Manages undifferentiated symptoms. It makes it instantly clear which bits of a huge topic are actually relevant to your specific enhanced scope.
And I guess for the people teaching and supervising, that clarity must be huge too. This kind of framework forces a structure, making sure that the teaching and assessment are actually building skills progressively towards those big outcomes, not just, ticking off random topics.
Absolutely. But probably the biggest practical reason for this change is consistency. It's about future-proofing. RCEM has already moved consultants and ED-ACPs over to this SLO-based system. So adopting this language now means EPs are speaking the same language, using the same standards as the rest of the ED training world. It helps create what the sources call a seamless progression.
That consistency does sound really powerful. But hang on, before we dive deeper into the EP role itself, we should probably clarify the official status of this particular framework we're discussing.
Yes, that's crucial. This document, the one mapping the SLOs, it's a non-formal tool right now. Think of it as an organizational guide, an interpretation. It's not officially replacing the national EP curriculum, but it is using that SLO language to help EPs and their supervisors, align the learning outcomes and really demonstrate progress using that common, well-respected language.
Got it. Okay, so let's pivot then and really lock down the definition of the EP role itself, because this is where the professional boundaries are drawn, isn't it? The sources clearly define it as an extended, enhanced level of practice. That sounds very specific and, importantly, distinct from advanced practice. Why does that distinction matter so much for you listening?
Well, it boils down to scope and ultimately legal responsibility. Enhanced practice means you're operating with more skill, more autonomy, but within a defined scope. And for the EP, that scope is basically the autonomous management of patients with minor injuries and illnesses, mostly in the minors area, maybe the waiting room. Advanced practice usually involves more complex cases, undifferentiated patients, maybe critically unwell ones. Keeping that enhanced distinction makes the EP's focused expertise really clear.
Right. And given that focus, why the big push for a standardized curriculum like this SLO mapping if the EP role is kind of already established?
It's like professional armor, really. A standardized curriculum gives you a solid, measurable way to show competence. And let's face it, in the world of autonomous practice, if your professional integrity ever gets questioned, this framework provides concrete evidence of the structured training you've done to justify using that title. It protects you, the practitioner.
Okay. And looking at the pathway the sources describe, it seems pretty clear. You start as a trainee emergency practitioner, a TEP, that's typically band 6, and you need at least 5 years clinical experience beforehand.
That's right. And then that TEP progresses to become a qualified emergency practitioner, an EP, at Band 7. The whole training period to get to that independent, enhanced practice level is generally set at about 18 months. And that includes the necessary supernumerary time, consolidation, all needed to properly embed those autonomous decision-making skills.
And achieving that, well, the educational requirements sound pretty demanding. What are the key things a trainee needs academically and practically?
Academically, you need level 6 or 7 modules specifically in minor injury and minor illness. Then practically, there's a whole list of mandatory certifications. IR/MER, image interpretation, plastering and splinting, suturing, and of course, up-to-date resuscitation training.
And crucially, it's not just about passing courses. You have to actually demonstrate the skill on the floor, right? Performance assessment is key.
Absolutely. The assessment relies on validated workplace-based tools, and these aren't easy tick boxes. They're designed to ensure safety. We're talking DOPs, direct observation of procedure, CEX clinical examination exercises, CBD's case-based discussions, and also multi-source feedback, MSF. And the whole thing needs a designated coordinating education supervisor, ideally an emergency consultant, to oversee it all and make sure the sign-off is rigorous and defensible.
Okay, here's where it gets really interesting, I think. Moving from the sort of academic structure to the actual clinical application, the boundaries that keep practice safe. Let's look at clinical safety. That's SLO 2 and 11.
Yes, this is all about managing risk and good clinical reasoning. The proposed curriculum gets very specific about where an EP's autonomous practice should stop, basically forcing an early discussion with a senior for certain high-risk presentations.
And what are those specific red flags? The absolute stop and discuss points.
The list acts as a very deliberate safety net. EPs generally shouldn't be seeing patients autonomously without senior input if they present with atraumatic chest pain and are over 30, or if they have a fever and are under 1 year old. Also, abdominal pain in anyone over 70, or really anyone with a new WS or PEWS score over 5, or even just a single parameter scoring 3 or more.
That's fascinating because those boundaries, they don't just protect the patient, do they? They also strategically shield the EP from getting drawn into those really high acuity situations that fall just outside the defined minor scope.
Precisely. It clearly marks out the territory for safe autonomous practice while making sure those high-risk, maybe less frequent presentations get escalated appropriately.
Okay, now let's switch to the hands-on stuff. SLO 6, procedural skills. Since EPs work autonomously, the curriculum insists competence here needs formal assessment using DOPs, direct observation of procedure. This isn't just knowing about it, it's actually doing it properly.
The sources lay out a pretty broad range of skills needed for the minors area, things like advanced wound closure using mattress sutures, skin glue that requires real dexterity.
And complex foreign body removal, too.
Yeah.
Not just simple splinters, but things needing a slit lamp for eye injuries or removing embedded things from ears, noses, skin.
Exactly. And naturally, immobilization techniques, applying soft casts, Zimmer splints, volar slabs, ulnar gutter slabs. These DOP requirements mean that when an EP is signed off on this SLO, you know they can actually perform these common day-to-day procedures competently.
And just to show the kind of depth we're talking about, let's look at just specific clinical areas. Take musculoskeletal stuff. The SLO framework expects more than just spotting a fracture, right?
Oh, definitely. It demands a much more comprehensive risk assessment. For example, under lower limb competencies, EPs absolutely must be able to assess the VTE risk, that's venous thromboembolism, for any patient needing immobilization, and then manage that risk according to the local guidelines.
Right, and we see that same depth in pediatrics, too. You mentioned the limping child earlier. That's a common enough presentation in minors, but it needs a careful approach.
Absolutely. The curriculum requires specific skills in managing things like the limping child, which, as you know, can hide serious problems like septic arthritis or a slipped femoral epiphysis. And beyond that, the framework specifically states EPs need a high index of suspicion for non-accidental injury, NAI. That means knowing safeguarding procedures, recognizing suspicious findings like certain frenulum tears or odd burns.
So pulling it all together, what does this alignment with RCEM SLOs really mean for you, the emergency practitioner, day-to-day and for your career?
Well, I think it means we finally get a common language. It helps supervisors, consultants instantly recognize your skills and competencies, moving beyond just relying on, variable past experience. It lets EPs and TEPs clearly show how they're progressing using the exact same high standards that their consultant colleagues use.
And this structure seems especially important when you think about all the different professional backgrounds coming into the EP role.
Mhm.
Nurses, paramedics, physios, pharmacists.
Yes, it's critical for that reason. This structure helps pinpoint specific training needs right away. Say you're a pharmacist moving into an EP role. The framework makes it obvious you'll need focused training on maybe extensive patient initial assessment and physical examination skills. Whereas a paramedic trainee might need to develop phlebotomy skills or perhaps more advanced limb splinting to meet the full scope. It just makes the training much more targeted and efficient.
So ultimately, this SLO mapping aims for high consistency, high quality across the whole ED team by really standardizing the EP role and defining its scope precisely.
Exactly. And maybe here's the final provocative thought to leave you with. This framework sets national standards for the EP role, defining its boundaries and competence. But the sources also make it clear that the local department still gets to define how the EP role functions day to day to meet its specific workforce and patient needs. So the question is, how might this national standardization, which defines the scope, actually end up enhancing the flexibility of local departments, allowing them to tailor their EP team to meet unique local challenges? How is this framework going to shape the next phase of multi-professional working in the ED?